Hello, and welcome back to the Off Service Podcast. So, when I first started this podcast, I was very concerned that I may end up with just 100 guests who are all occupational medicine physicians who moved away like I did. But I was very, very grateful to have met somebody with a completely different career course. And she was very gracious with her time and is willing to be our second guest. So, I'd like to introduce Robin Cooper, MD. Thank you so much for being on the podcast.
Oh, you're very welcome. I'm so excited to talk to you.
That's when I first met you and you handed me your business card. As soon as I read the first two words on it, I was like, gotta have this person on the podcast. Very interesting.
You're flattering me.
Very on brand for just like really letting people see what options there are outside of just seeing patients. And so as a way of introduction and to give people a sense for what you're involved in now, what do you tell people now when they ask you, what do you do?
I say I'm a psychiatrist. It's been my long career, but right now I am involved as a climate psychiatrist. And my second career is in the realm of being the co-founder and president of an organization, Climate Psychiatry Alliance, which is focused specifically on the mental health impacts of climate change. So I say, those are the two parts of my identity and career.
And so, could you explain a little bit more about what your day-to-day work looks like and what's that split of clinical to non-clinical work?
Well, I'm very, very near retirement in my clinical realm. And so I have a small clinical practice. And of course, I try to keep up with the needs in that area. But my day starts with, like many of us now, how many emails are in my inbox? How many do I have to get through before I have my second cup of coffee? Because the components of running a small nonprofit, of which I had no training, have brought me into a sphere of managing an attempt to do all sorts of things that in the realm of climate psychiatry. And I know that we'll talk more about that.
Yeah. And so, and what percentage of your time would you say is spent doing direct clinical care nowadays?
Oh, very, very small. I have maybe 5 hours a week of patient care. I consider myself semi-retired in my clinical work. Although I just do want to say that my clinical work and my work with patients has been enduring in over 40 years, and I'm not giving it up because it has not been satisfying. It's been an extraordinary career, an extraordinary ability, and a gift to be able to be that involved with people's lives in ways that are important. So it's not that I don't cherish that part of my older part of the career, but I am in new directions.
Great. And so, all right, we're going to come back to climate psychiatry, but let's take it way back. So, when you were first deciding to go to medical school, what attracted you to that degree?
Well, we're going to go way, way back. My mother was a psychotherapist, a fairly prominent psychotherapist in the Bay Area. She trained many people in clinical skills of my generation. But way back, my cousin and I, when we were kids, 8, 9, 10, played therapist. And we had our little charts and we wrote down names and problems that our patients had or our clients had. I remember the problem that we consistently faced with our clients. They were afraid to go outside in our idea, and we took them outside. So where I started with wanting to be a therapist was when I was a kid, and my mother was a significant role model in that. But she was a social worker. I had intended to go to social work school and learn how to be well trained as a therapist. But one of her colleagues suggested I might want to do that by route of medicine and become a psychiatrist. So after I completed college, I went back and did all of the pre-med studies. I went back to Berkeley. At the time, actually, my father was getting a second degree, so we were on campus together. I finished my pre-med, and you may have the kind of sense that once you get on the route to be a doctor, it is kind of on its own path. So I went to medical school with the passion and intention of being a psychiatrist. I toyed around with other areas, but my skills and my talents and my interests always brought me back to psychiatry.
Got it. So even from the beginning, I think medicine can attract people sometimes that are more task oriented, and it can also attract people that are more interpersonal oriented. So from the beginning, you've been a talker.
I hope I'm a talker, yes, from the beginning. I hope I did develop skills in knowing how to listen.
Sure. Yeah. Right. And some technical skills, of course.
And also, just in the course of my career, although I've been a clinician primarily, I've always had my finger a bit in supervision and education through my varied roles at UCSF. And one of the things that I think is amazing about being able to say to young people who are pursuing a medical career is there's so many ways to be a doctor. There's so many ways, just as you've kind of articulated. It can tap into a lot of skills and capacities and tendencies about the way we are.
And just out of curiosity, since you're the first psychiatrist we've had, psychiatry does always feel a little bit different. It kind of feels like there's surgery, medicine, and psychiatry. I don't know if you agree with that, those buckets, but what were the other things in the running for you when you were in med school that you considered?
I did think about pediatrics. And pediatrics is, of course, the medicine for young children. And that was before I actually did my pediatric rotations. I thought that might be an area. Then I discovered that kids can get really, really sick. And that was not something that felt good to me, to have to work with children, and it breaks my heart when they face those difficulties. So I went back to what's really suits me best.
Yeah, I mean, I think that's another important lesson, which is a lot of specialty choice is personality. There's stuff that's interesting. There's stuff that's rewarding about any specialty. That reminds me of my father was a general surgeon in Ireland. And then when he came here, he had to decide he had to redo his training basically. And he thought, let me do the most challenging thing. Let me do neurosurgery. And the outcomes are, can be poor. And so that was too stressful for him. And so he ended up doing a different specialty.
I feel really lucky that I was able to make decisions that matched my temperament and my style. And I think that is really important for everyone now. And I do say it in the same way for when I advise people who I'm working with in the realm of climate change. Do something that fits your personality, your temperament, what you know, what you are passionate about. There's a place for all of us.
Yeah, there's definitely no lack of things that need talented people's attention. So great. And then, okay, so when you were in med school, did you have a vision for what type of psychiatry work you wanted to do, like any particular population or any particular approach?
Not in medical school, primarily. And, you're making me think about how much have I distorted over the many, many years. So I'm not really sure how this emerged. At the time that I trained, the field of psychiatry was not as broad as it is now. And psychotherapy was a primary core aspect of psychiatry. And that I knew I wanted to do. I knew I wanted to work with people in the realm of what we would call talking therapies as a psychotherapist. But over the course of my training and then, of course, my career, the field of psychiatry has become much more diverse. There are much more areas that we now bring to the field that have to do much more with biology and pharmacology, and those are added components. But I've never ever not seen myself as a psychotherapist.
And then after medical school, what kind of training did you do?
I went directly into residency training. I came back to San Francisco. I went to medical school in New York, and started my residency at UCSF at Langley Porter. That probably was the time when I started to clearly shape a path more in what I wanted to do that actually had to do with differentiating myself from my mother, who was at the other major training site in San Francisco at the time. Mount Zion then was a very separate hospital. It was not part of the broader UCSF system. And so I needed to find something that was mine. And my mother did child work, so I became very clear I wanted to work with adults, and I think it fit my personality better. I did a little bit of work in group therapy, which was also something that she did not do. And so my temperaments and the things that I were good at also helped me to shape a direction that was mine.
Got it. And all this figuring out where felt like the best fit for your personality and your interests, that was all during residency?
No, I think development happens over a very long time. So actually, post-residency, although during residency I began to learn how to lead a team, do treatment for severely and acutely ill people in an inpatient setting. I learned a little bit about how to begin to think about teaching, and that was my first job out of residency, medical student education in our Department of Psychiatry. That helped to develop skills in mentorship that I still use. But after completing my residency and developing my career, other aspects of what I cared about became important. So I had a private practice of psychotherapy and psychiatry that combined the many skills. But I also had a commitment to providing services and making accessible services to people who don't have access to care. So although I didn't primarily work as a community psychiatrist giving care in community clinics, I always had my finger in the sense that it was important to work in policy that would promote access to care for severely mentally ill. And I also worked clinically with a small group of psychiatrists in San Francisco who provided direct care to the severely mentally ill who lived in board and care homes. It was the era when actually there were some decent community members who housed people with severe illnesses, schizophrenia, in their homes. And so that was another component that developed out of my commitments to the social aspects of care.
And then, so already that's like 3 different careers. And so after residency, was your first, did you do any post-residency training?
Nah,
Okay.
done with that. Although I don't think you should I didn't, no formal training, but we don't know all that much when we come out of residency. So, keeping abreast, and I always had consultation groups and things like that I participated in.
And then, so after residency, was your first gig a private practice?
No, it was actually a half-time job at UCSF doing medical student education, of which my private practice was incorporated into that job.
Got it.
So I was actually, I guess it was a full-time job, but I was doing my practice as a part of that.
Okay. And then you talked about some community practice, some in-home practice. I'm interested to hear about the policy piece. Could you speak more to that?
It's an incredibly important area that I think is really important, and it stays with me right now in this second career, climate psychiatry. But at the beginning, and you cannot do policy work that influences anything about healthcare or psychiatric care or climate health or climate mental health without being embedded in a group. It is just not something you do alone, and you have to have associations with groups of people and groups of activists. So I would, stretching my memory, I guess the group that I was most affiliated with early on was the San Francisco chapter or group affiliated with the Northern California Psychiatric Society. But I worked very much within a group of San Francisco folks and advocating for policies that would influence access to care primarily for severely mentally ill. And out of that, I became, oh, you're really stretching my memory in terms of the names of these things, but I became the psychiatric consultant to one of the state advisory groups on provision of care and access to care for severely mentally ill. And I did that for a number of years.
And what kind of input is a group like that looking for from an MD and from the policy realm?
Well, what I think I bring and what I think I brought then was not was understanding what the nature of the difficulties are that people with severe mental illness has, what their needs are, what the barriers that they experience are in their direct lives, so that policies can address some of those gaps and barriers.
You know, I anticipate some people who I'll have on this podcast will understand clinical work and whatever non-clinical work they do as completely mutually exclusive things. The way you're describing it, it sounds like your entry into policy was sort of a natural transition from your clinical care. Is that an accurate assessment?
It's the foundation of what expertise I could bring, but my passion for influencing change that I think is progressive in our world goes back way, way again into my earlier lives. And I've never been not caring about the social issues that influence us and being somewhat of an activist. So it's a marriage of commitments that I had and prior political activism and the skills and knowledge in the area of psychiatry that I had. And that I think is really important because we, all healthcare professionals, have unique knowledge that we can bring to bear, I believe, on helping the world be a better place.
Do you have a sense for what it is about the sort of way of thinking that is taught in medical school that's helpful even outside of purely clinical care?
Well, actually, I sometimes I think that the way we get trained and think in medicine have to be set aside and redone. And and sometimes we have to rid ourselves of some of what has been trained in our identities. We really have a very hierarchical healthcare kind of delivery, a way that we organize things. We have special skills and talents and knowledge, but it's so important to know that there are others also, and that we join together, and that we respect and work collaboratively. And sometimes I think some of our training needs to be beaten out of us to be able to do some of that.
Yeah, it's always funny to me anytime someone talks about medicine as if that's the only type of medicine that doesn't need a qualifier. I like when people call it whatever allopathic medicine. That I think helps frame it, and I think is really helpful for patients too. There are certain disease states that the way allopathic medicine is taught and is managed and is funded is very good at treating. Anything you can see on an x-ray, pretty much we're good at in the biomedical model. But to deal with a lot of other things, it requires, breaking down what assumptions, what you think the limitations of what can be done are. When I think about medical training, I often think the best lesson I learned was probably like a pretty basic one about due diligence. Just work hard, make sure you are anything that can lead to catastrophic failure, loss of life or limb. Make sure you're double checking, triple checking that. Use checklist. I feel like that's the skill set I bring mostly to non-clinical work that I do. A lot less the sort of rote memorization of.
Well, I think I completely agree, and we bring that precision in our medical training. But what we also and over time, I think this has only gotten worse. We silo ourselves in our little disciplines as if we think only about the part that is coming before any particular medical person. And people are whole and complex and multi-leveled, and that needs to be held. And there are many ways that people can be helped that don't only have to do with the little slice of what any particular specialty brings.
Okay, so you are you come out of residency, you're a practicing clinical psychiatrist, and you're already expanding beyond that to deliver care not just in the clinical setting, but also maybe in people's home setting to work more in the community. And then you expand beyond that to think about policy, more the social probably determinants of health or access to healthcare. So tell me, how do you break the silo into environmental health?
I, as I said, I've always been involved somewhat as a political activist. And as in my residency, I got involved with nuclear issues. And when I learned about nuclear potential annihilation,
What year was this?
69, 79, 80. I started my residency in 79. PSR, Physicians for Social Responsibility, was involved in nuclear issues. I was involved in nuclear disarmament issues. But when I learned about nuclear issues, and I brought it to my residency class, it was like this gut punch. Oh my God, what could happen to our world? And then I think many of us got kind of like complacent, and we thought, well, there's international agreements, and the risk of nuclear disarmament, the advances in nuclear disarmament are so wonderful, and we're safe, and blah, 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 blah. That coincided also with my growing career as a young clinician, my having family, children. It gave me that breather. But much later on, that same gut punch happened when I learned about climate change. And it came about after a particular political election I was involved in, and I ran into some people at a march about something, I can't even remember it, and they were leafleting, and I went to a meeting and learned a bit about climate change. And that was like at a time when I actually think we could have done something to turn this crisis around. But I had that same sense, oh my God, the risks here and the potential for such profound impacts on human and non-human life are so significant. And it was different than the times I would work on a political campaign and then be so relieved at the end of the election. Oh, now I can go back to my life. I could not give it up. It was penetrating. It was enduring. And I started to investigate where I could be. And logically for me, I continued with my clinical practice, but it was quite separate. And I got involved in several political groups that were working on climate change, gravitated to work primarily within Citizens Climate Lobby, which for me was the most, fit me the best for who in the group I was working with, and because I thought it addressed the economic foundations of the climate crisis. As I learned, I toyed around with where I would fit in, and I eventually, it took a while, thought I need to work in that organization within the climate health subgroup. I can bring my knowledge and my identity as a healthcare person to that. And in the course of that, lo and behold, when people talked about the health impacts of climate change, there would be an infectious disease person or a pediatrician or someone in the realm of other areas. And at the end, they tack on a talk, oh, and by the way, there's some mental health issues associated with climate change. This felt to me horrifying. Where are we, the psychiatrists, in bringing our voice to this? We cannot abdicate and be second fiddle to that and dilute the mental health impacts. And I don't quite remember, but how I found like-minded psychiatrists in the United States who were all kind of bubbling up with the same kinds of things. We need to have our voice, and we need to own and bring to this movement and this understanding the psychiatric and the mental health impacts. And I began to develop, and we had beginning meetings about how we could form an organization, how we could learn more, how we could develop what has emerged over the time and actually expanded enormously, the field of what I would put under the umbrella climate psychology, climate psychiatry. We've gone gangbusters in making sure that the content is brought to the discussion and that the information and what we understand can be applied in many ways, effectively, we hope, effectively to bring the message. That doesn't mean that I'm always so convinced that we will be able to manage the many forces that are challenging us.
Yeah, at first glance, when I saw the word climate and psychiatry next to each other, it wasn't obvious to me what the connection was. But then hearing you talk about it now, it's everywhere. I mean, there's like a real existential dread about what is going to happen. I've heard many people talk about, should I even start a family because I don't know what this world's going to look like? Can I buy, is it worth buying a home in this area? What are...
Well, today, many of us would have wanted several weeks ago to have a house in Southern California, and I don't think people want to buy there now after we're facing the fires now. And you're talking about something that is really, really important, that existential dread, that sense of what has been publicly seen in the media as eco-distress, climate distress, climate anxiety. You brought up the challenge that young people have. Should I have children in this world? And I actually mentored a young undergraduate student from Yale in writing an article about that. That's really important. But I think people think that the scope of mental health and climate change is limited to that distress syndromes. And it is not. And that's one of the things that over my identity as a climate psychiatrist, I have learned. and that we want people to know about, that there are lots of complex ways that the climate change and what we're seeing have direct impacts on behavior, cognition, mood regulation, individually for individuals, community integrity and community cohesiveness. So heat creates aggression and suicide, independent of all those other social determinants, but is known to be a multiplier of aggression and suicide. Heat has dramatic impacts on cognition and the ability to learn and pay attention and make decisions. You've worked in the realm of occupational health. There are increases in work-related accidents due to heat alone because of impairments in being able to concentrate and make appropriate decisions. Heat has direct impacts on sleep and sleep cycle, which impairments in sleep have vast impacts on all of those things: behavior, mood, thinking, decision making. Disaster psychiatry is a whole nother field. I mean, we're looking at fires destroying massive communities in Los Angeles now. So the field of disaster psychiatry is really, really important in managing both the acute stress experiences that people are having, but the post-traumatic stress that is profound and can be debilitating and can last for years, and depression and substance abuse, and again, interpersonal violence that is erupted there. And then add on that displacements and people having to move because of disasters or heat or places that they can no longer live. The difficulties with slow-moving disasters, sea level rise, drought, changes to our environment, have extraordinary emotional impacts. And there's a funny, fancy word that kind of doesn't flow off the tongue very well. It's called solastalgia, which is a kind of deep grief that people experience when the world that they've lived in that has brought solace no longer does. It's kind of like being homesick while you're at home. And then that whole area that you've brought up in the distress, that's so profound with youth, primarily young people. So that what I've learned and what the field has learned in the course of the time that I've had my finger in this big bucket is that there are lots and lots of things in this umbrella of climate mental health.
Yeah, hearing you talk about it, it seems so obvious. I think a long time ago we understood, again, with the biomedical model of human health, how the exposures, toxic exposures in the environment can change our physiology and lead to pathologic states. Uh, why wouldn't it be the case that the environment that we live in can affect our mental health, our psychiatric health? And we're not separate from the environment. We're part of the environment.
So important, that connectivity, that we are a part of the natural world and we impact it and we're dependent on it.
And so clear to me that your training and your experience in clinical psychiatry, working one-on-one with patients, has helped you advocate and move things along in the policy realm and the population health realm. What about the other way? Did you find that your work doing climate psychiatry and policy work has influenced your clinical care?
I think you're asking a bigger question, though, is how do clinicians think about the appropriate places that the information and their understanding about climate and its impacts has on patient care? How do we listen when it comes up? Because most people don't experience their doctors as a very welcoming place to bring a concern about the broader environmental world that we live in or climate. It's not there unless we listen and pick up when it's appropriate and respond to it and open that area when there are concerns, particularly in the realm of psychiatry. But there are very specific ways that clinicians, I think, have a responsibility and a role that needs to be played. Just like pediatricians always ask, do you have a car? Do you put your kids in a car seat? I think the same questions have to begin to be a part of clinical care when we're facing the extraordinary impacts of heat. Are you prepared in this? We know in a clinical setting, saying to a patient, we know that we can expect more extreme heat. Are you prepared to take care of yourself and those in your family for those inevitable periods that we're going to face about extreme heat? And we've developed toolkits, and I developed one, and there are many that can be utilized that way. Same thing about disasters. I mean, the same kind of question. We know we are all vulnerable, and we are not always thinking about how to be prepared. Do you have a go kit if you need to leave during any disaster? Those are appropriate things. And we don't have to not do what a patient is there for us at any particular moment. But there are now, because of so many sophisticated things, ways that we can help clinicians to know how to help patients. And I know at UCSF, in the EPIC post-visit, there are ways that we can send out information, and that's being used. And thankfully, you know who has helped to push that along?
Who's that?
Medical students.
Oh, great.
Medical students. Wonderful.
It resonated with me when you said give physicians, exactly what you said, tools or the knowledge to know what to do. I think a lot of times clinicians are hesitant to go down pathways that they can't solve in the 15-minute time period they have with the patient. But if there's ways to route people to connect to other resources.
Exactly. It is a burden, and docs don't want to open up something that they don't have something to do about. Yeah. We like to be effective and do stuff, and not everything has a doable answer, regrettably. It's actually one of the skills or one of the things that my field of psychiatry, I feel, has helped me, is that we don't always have the answers, and being with people is important. But in a 15-minute visit for someone, let's make sure clinicians have tools and that they can rapidly deploy, or systems where the nurse or the person in the waiting room or the assistants can help with this. And the more we make those available and known, the more we can help clinicians not feel so fearful about treading into this area.
In order to give listeners who may be interested in climate psychiatry work a little more of a tangible sense of what kind of work they could expect if they got into it, could you give an example of a success that was particularly memorable to you or particularly impactful?
That's a complex question, answer. One of the things that I think is so successful and extraordinary is the creation at UCSF at the Center for Climate, Health, and Equity that is specifically working on the multiple ways that climate and equity are important to both have an impact on health education and then service and policy. And I think that that's different than a moment that I can bring up in my mind about a specific success, but having a contribution into those bigger organizational things. And that's just here, but it's happening at many institutions, Columbia, Yale, a number of places in Washington, D.C., where I'm particularly working now on developing a fellowship in in the realm of climate psychiatry. There are other fellowships that are happening in healthcare. University of Colorado comes to mind, particularly at this moment.
That's great. I think especially clinicians, we're very can be very credential oriented, and so having a formal program with recognition sometimes helps
Yeah, you
attract people to
can't
it.
you can't get health education unless you have a question on a board exam. And so there are people working on that. I'm not interested in it, but colleagues of mine are doing that. I guess one of the other successes I've had, which comes out of a model of how you do medical training for things that really have to do with social determinants of health, is how we embed the information in a medical education where there isn't a second that anyone is going to give up, and it's already so tightly packed. So I have been successful, and there's people who have thought more deeply about this than myself, but getting the clinical examples that are climate related embedded into the content of a training. So when you talk about post-traumatic stress is one of the topics in a medical student required course. The instructor is using now a climate example, and it's similar in other kinds of content areas.
I loved that the example you gave was the educational example because your effort is amplified by however many students you train. It has a better chance of changing the culture because you're kind of implementing it earlier on in the training program, and it becomes more accepted idea to expand beyond what we narrowly consider the realm of a MD.
You are absolutely correct. So that when this model, and there are leaders in medical education who are promoting this, happens in psychiatry, in infectious disease, in pulmonary, in a pediatric, in whatever pediatrics, in cardiovascular, in neurology, it gives a repeated experience over time with nuggets that create a informed and literate physician core workforce going into the future. And that I think is really important than just having a carved out single class that then you get through and you take the exam and you forget it.
And for anybody who's watching who's interested in education, it's fun. It makes everything interesting again, even if it's
Yeah,
something you've done 100 times because somebody may have not seen it before.
I agree. And that's what's wonderful about our profession. Because if you've seen the illness a zillion times, you haven't seen the person that illness is in. And that's, to me, so wonderful.
As you were moving away from purely clinical work and you were incorporating more non-clinical time into your schedule, did you how did you feel about that? Did you have any sort of hesitations about decreasing your clinical hours?
That's an emerging process through aging. And I am like thrilled that I have meaningful work that goes beyond just my 40 years as a clinician, and that there's been an ability to be proud of the work as a clinician, but now I'm doing things that are profoundly different, learning skills about how to manage and run a nonprofit small group is a whole new body of stuff for me. And I'm developing some of those skills, and they're big challenges. But it's like wonderful to do something that is meaningful to me.
So the medical side, we go to medical school, we get a degree, we go through a training program with standardized milestones. We pass a board exam that generally gives people a certainty that this is something I'm qualified to do, either in clinical medicine or when you expanded beyond clinical medicine. Any part in your career you ever felt imposter syndrome, like you weren't sure if you felt qualified to be there or wondered why anybody should even be listening to your opinion?
I think that's a component that all of us have. Some where it takes over more than others. I suppose I felt it when I was in medical school most, and that's in part for some of the ways that I learn and that were challenges about medical school. I have an auditory processing kind of thing, and I couldn't hear that the words that were being said were the same ones I was reading in the textbooks. So making that association was really hard. And early medical school is like learning a language.
Yeah.
But I think, as I hope with other people, as you develop an area that you really can be good in, you can not feel so much like a fraud, but like valued for what you bring, and know that what you don't bring, someone else can do. And that's also a component of what I have to think about now as I navigate the climate work. What are the parts that I can bring? Because I can't do it all. And what can others do? And that, I think, also is climate psychiatry ain't gonna do, cannot solve the climate crisis. All we can do is bring what we have in our lane, and then others in their lane, whether it's medical or healthcare or the vast political activities. We all have to do that together, honoring what we bring and what others do.
If you could do anything different about your career, would you have made any different decisions?
I don't. I don't even think about that.
Okay, that's a
I
good
mean,
place
I
to be
don't
at.
even think about that. You don't plan out your career. You grow into things. And when you grow into things, there are doors that open and other ones that close. There were choices. I don't know.
Love that. I
I,
love that
I
idea.
wouldn't. I wouldn't. I mean, it's not that I would say I'd never do anything differently,
Yeah.
but you get some things and you don't get other things.
You grow into things is great. I actually like that better than one door closes, another door opens. And then for anybody who might be interested in expanding beyond clinical work, whether it's particularly about climate psychiatry or just anything, do you have any advice for them?
Do something that is close to what you care about, and think about what matters to you, what your values are, and apply whatever skills you have to that. Do something close to what you already have. And for me, what I would say is bring whatever it is that you can do, into the realm of making changes in our world. I always advocate for joining Climate Psychiatry Alliance, but for anyone, find that place that you can wed your passions and what you're committed to and your skills to. And that's really important now because we are facing massive experience of burnout from healthcare providers, and it is primarily because of the structure and organization of healthcare delivery. And that's very, very sad to me to hear people early on in their career sick of what they're doing. When I've had a 40-year career that's been so gratifying.
And
I actually have one other thought that I want to bring up. Because we're talking about, shifting careers, changing course, moving out of clinical care to something else, moving away from what we're primarily trained as. For me, it's not that I have shifted because of dissatisfaction. I mean, I might have, I'm older, I might have been moving toward retirement. I value what I did before, and this is just a different, compelling way for me to have what I consider a second career.
And if people want to find out more about Climate Psychiatry Alliance, where should they go?
ClimatePsychiatry.org. Right there on your website. Just go on, just Google Climate Psychiatry. There's lots of stuff, and I'm always thrilled to talk to people, so you can find me there too.
Well, thanks for joining me today. I appreciate it.
Thank you. It's been a pleasure.